Hi everyone, my name is Vincenzo Berghella. Once again, welcome to AJOG MFM Live, doing updates, this time about the May issue. Dr. Mhatre is with me. Mo, always a pleasure.
Thanks for having me. Hi everyone, hope you all had a wonderful Mother's Day. I am Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center, and I'm the director of the MFM Fellowship at Tufts. Here we have our May 2025 highlights. We have our list of our articles here. For those of you who are unfamiliar with our format, we do try to select from all of the fantastic work that's been published this past month. We try to highlight 4 articles that we think have a rigorous study design and are also very helpful for counseling and management of patients either in the office or on labor and delivery. And we try to select articles that are helpful not only to our MFM colleagues, but also to the other providers who are caring for pregnant patients, such as our advanced practitioners, family medicine docs, generalists, midwives. As usual, we're going to be using visual abstracts to have a high-level summary of the articles, but please feel free to look at these articles in detail on the AJOG MFM website. And with that, we're going to start with our first paper with Dr. Berghella.
Thanks, Mo, and again, thanks for these infographics. They're fantastic. Look at this one; just gives the meat of it, right away. It's a very hot topic. If to use Lasix postpartum for accelerating recovery in patients with preeclampsia, another randomized studies, and there are now quite a few of them. This one randomized 60 patients to 40 milligrams of Lasix daily for 5 days versus placebo. 60 placebo. Again, these are postpartum patients with preeclampsia with severe feature or eclampsia and adequate urination. And the ones that were on the active ingredient, on the Lasix, they had, not surprisingly, a decrease in the mean daily blood pressure the first 5 days, shorter time to control of blood pressure, and no differences in number of antihypertensive. And other studies have looked at this similarly. I know that some of your institutions are giving kind of routine Lasix postpartum to patients with preeclampsia, especially severe preeclampsia. It's certainly tempted, another positive trial. I like to see more substantial outcomes, more, decrease in maternal morbidity. Obviously, if you give an antihypertensive, your blood pressure will decrease, but it's certainly, if your blood pressure decreases, probably if you have bigger numbers, you'll have less, eclampsia, stroke, and organ, disease. So I like this even small randomized trial.
Yeah, and I think this paper also, just one of the limitations is it didn't follow the patients afterwards. So we don't know how many bounce back. We don't kind of know the long-term outcomes of those.
Readmission is a big deal. Right.
Yeah, so more to come, but definitely a very interesting study. The second paper we're going to do is looking at survival rates in pregnancies complicated by twin-to-twin transfusion syndrome undergoing laser therapy. This was published by a group based in Italy and the UK. And so many of us know for more monochorionic pregnancies, twin-to-twin transfusion or TTTS is staged with the Quintero staging. But one of the limitations of that staging system for diagnosis is it's not as helpful in necessarily telling us the prognosis of pregnancies, especially after they're treated. And there's been some suggestion that, perhaps the differences in prognosis between stage 1 and 2 are not that different, but maybe they're a lot different than compared to those treated with stage 3 to 4. And so this group was seeking to evaluate that question a little bit further. And so they did a systematic review of 3 databases. They picked pretty contemporary articles earlier than 2010 and found a meta-analysis or performed a meta-analysis of 26 studies. They looked at the prognosis of patients who had laser somewhere between 16 and 26 weeks. Because outside of that range has higher risk, and they wanted to avoid any cases that included selective fetal growth restriction as well as either chromosomal or known structural anomalies. And they found a total of about 1,600 patients that were either stage 1 to 2 or stage 3 to 4. And they had outcomes at birth. Looking at the double survival at birth, they found that there was a significant difference between the paired of 69% in stage 1 to 2 versus about 50% in stage 3 to 4. And you can see again differences in survival of one twin between these paired groups, and then between no survival. When you looked between stage 1 and 2 in particular, or stage 3 and 4 in particular, and compared them to each other, there wasn't much of a difference. So this group did see that there was what makes clinical sense is that the perinatal survival for twin to twin after laser is higher in stage 1 and 2 compared to stage 3 and 4. But finding that there's a difference between these kind of paired off groups suggests from this study that perhaps they need to have a more simplified staging. And then maybe that can help us not only for diagnosis, but helping us counsel patients for prognosis. So very interesting, and hopefully some more will come out of similar studies as well. Oops.
So I'll do breast stimulations versus low-dose oxytocin for labor augmentation in women with a previous C-section, another randomized trial. So, high-level studies. So breast stimulation has been studied a lot to augment or induce even labor, but this paper is particular because it looks at TOLAC, people with a previous C-section trying to have a trial of labor after C-section. And again, where they're initially dilated, kind of in the early latent phase of labor, they need labor augmentation, and the labor augmentation of 33 patients with breast stimulation via breast pump. And it is beautiful infographic, again, by Mo, 34 patients, the controls with, an oxytocin augmentation like we usually do. And this trial showed that breast stimulation, kind of the novel intervention, was associated with longer time to delivery, a larger proportion of patients not in active labor within 12 hours, but no C-section no different C-section rate or no reassuring fetal heart testing. So we know the breast stimulation does work. I think this paper confirms that it is safe. And again, even if it's a small trial, compared to even low-dose oxytocin, maybe not as effective. So, if you want a more natural approach, it's certainly safe. But if you want, a more timely time to birth, oxytocin seems to be better, at least to breast stimulation as studied in this small trial.
And then finally, this is a study looking at the role of incorporating maternal fetal medicine physicians on labor and delivery in an effort to reduce maternal morbidity. So very interesting, as the U.S. model for delivery care, it doesn't always have an MFM attending on the labor floor as part of the team. Many MFM attendings are in a consultative only practice. And so this study was done at an academic center in the health system. It had 2 hospitals, academic hospitals, and they did kind of a pre and post evaluation of how their outcomes were once they had MFM attendings only in a consultative only practice, which is about 31,000 deliveries. And then their post intervention, when they started consistently including an MFM attending on the labor and delivery team, which was about 21,000 patients. This was done between 2018 and 2022, and they did account for COVID. So they removed the year of 2020, given the heightened morbidity in that time period. And they also accounted for hypertension outcomes because they had also introduced a hypertension care bundle at that time. What this study showed is that having an MFM attending on the labor and delivery team significantly reduced severe maternal morbidity, reduced rates of postpartum hemorrhage, and reduced rates of maternal ICU admissions, even when they accounted for COVID and the hypertension bundle. And I think this really speaks to the importance of MFM on labor and delivery. And I think kind of adds to that argument that we can be really useful in many situations. And, there is a role for us on labor and delivery on the inpatient service. So this makes me feel good about my job because I spend time on labor and delivery. But it's nice to see kind of in a quantitative way how much we can make an impact. And I found this really fascinating paper.
I agree. I love this paper. I love this topic. And, I think patients are getting older, unfortunately, have more morbidities they start, the pregnancy with, obesity, hypertension, diabetes, etc. And, having better outcomes, it's so important. And it takes a team. Midwives are important, generalists, general OB/GYN are important, but clearly here it looks like, maybe for the sicker patients in MFM, in L&D, like many places have, makes a difference. And so really well done by these investigators. And thank you again, Mo, for wonderful infographics. And thanks to all the authors for sending us wonderful research that we can, get peer reviewed and eventually published. Continues to please send us your wonderful randomized studies, meta-analysis, large study like this one. AJOG MFM can really make a huge difference in the day-to-day management of millions of lives, mothers and babies worldwide. So thank you, and thank you again, Mo.
Thanks so much. Nice to see all of you, and we'll see you again next month. Take care.